So just one slide on what is the pandemic situation. So initially the coronavirus, when it was discovered, that we found that it has a tremendous potential of human to human transmission, with whole of the population not previously exposed to this particular virus. So that means everybody is susceptible to the infection with this particular virus. And initially we did not have any known effective preventive and therapeutic option. Currently we have vaccine, but efficacy is, although there are various claims which are there, we are still observing how it is going to behave in future course of time. So by the advent of the susceptible population and the potential uh, of the virus for human to human transmission, we had the pandemic, where we found that everybody is asking for RT-PCR report and doing that testing. So it was taken as gold standard because it could detect almost 60 to 70% of those patients who are infected. Rest of the diagnostic modalities which are available as on date, including the rapid antigen test, which is acronymed as RAT, is not found to be very sensitive. So the containment strategy became the test, trace and treat, or test, trace and isolate, but it has not worked to that extent that it can contain it or prevent the pandemic to happen. But largely it is the other measures, including use of mask, hand hygiene and the social distancing, which has more important role in containment of the pandemic. So when the pandemic started, it was like a blind man and COVID-19. Everybody has its own notion. Somebody will say that population, host vectors are playing role. So BCG can be given. So in the initial days, there were a lot of hue and cry for chloroquine and the azithromycin, that it will cure. And then every 2 weeks we used to have new drug, that this might cure, that might cure, and so on. Similarly, plasma therapy came into picture, that classically it is helping, but we now know that it has a very limited role in treatment of COVID-19. Similarly, so yoga, meditation, antibodies arriving, diagnosis. So everybody has some notion to play with, and everybody tries to prove that they are having some solution towards diagnosis or treatment of coronavirus infection. So as the things goes by, we became bit wiser and came to know of certain things. So here I'm just showing you this picture, which you are already familiar with, that there are some important proteins which are there on the surface, which are useful in diagnosis and for vaccine purpose also. So vaccine purpose detail you will come to know in afternoon, but just to show you that we have envelope protein. This is the gray protein, which is the whole virus has been covered by this particular protein, so it is known as E protein. So it has been encoded by E gene. Then we have these red spikes, the larger one, which are called as spike proteins, so they are S proteins. Then we have smaller appendages on the virus surface, which are being seen as matrix protein or the M protein, and so on. So there are many proteins, different types which are there. So why I'm emphasizing on protein here is that each protein has a potential to become immunogenic. That means each protein is going to have its specific antibody being produced into the uh, uh, person who is infected with the coronavirus, and we will see in due course of time which type of antibody is helpful in what manner for diagnosis or for taking the immune response into play. So here another important thing is that we have the spike protein, which is the major protein here, which helps in pathogenesis. So it is the one which is having the binding affinity towards the host cell. So the complementary receptor for the spike protein on the host cell is the angiotensin 2 converting enzyme receptor, or acronymed as ACE2 receptor. So when we cut it, you see, so this is a cross-sectional figure for the virus. You have the spike protein, which is helpful in binding, and then you have the nucleic acid also, where nucleoprotein is there, where it is saying that so this protein is also being used for diagnosis. We will see to it in coming course of time. So just to tell you that we have the SARS-CoV virus, which binds to the ACE2 receptors of the host cells, permissive host cell, and it is going to help it in binding and entry of the virus into the cell. And we have different phases of infection, which you might know by virtue of your uh, previous class on SARS-CoV, that in initial, or for that matter any viral illness, first is a viral contact initially. So once the virus establishes inside the host, the virus will be secreted or shed, so you can detect the viral nucleic acid, and over due course of time human immune response will take over and you will have the various antibodies coming in. So IgA antibody will first come because it is going to the mucosal surface, so local IgA antibodies will appear. Then is the IgM antibody, and then is the IgG antibody, which is going to come up. So the antibody response is supposed to provide you the immunity against this virus. So when we talk of strictly of the various timelines, so we have initially the asymptomatic phase, which generally lasts for 3 to 5 days, and in most of the cases it will have the containment then and there only, and the patient will remain asymptomatic and recover in due course of time by the advent of appearance of antibodies. In those cases where the disease manifests itself, the viral replication continues, and you have the antibody again coming into play. So IgM followed by IgG, and you have the viral RNA being shed into the uh, patient secretion. So here the important thing to remember is that when the virus is being neutralized by the antibodies, there still may remain the dead shreds of that particular virus. So RNA may still be detectable, as you see in this particular figure, despite the presence of antibodies. So that doesn't mean that that particular RNA is from the live virus. It may be the dead viral RNA which is being shed by the host after appearance of the neutralizing antibodies. So the various tests which are available will depend on what is there in the patient specimen. So in initial phase, you can detect the virus in form of viral RNA or viral protein, or known as viral antigen. So in initial 7 days, you have the viral RNA and viral antigen which is being detected. RNA again will continue for a bit period of time. It can go up to 10 days, and in few of the cases it has been seen that it is being continually shed, maybe more than a month, but generally that prolonged shedding is because of the dead viral RNA. Serology, if we see, the role starts, or the appearance of antibody, we see the role starts after 1 week of infection, and we have the IgM antibody followed by IgG antibody appearing into the patient's blood. So this is just to show you another picture how the antibody or the viral RNA is different in two different kinds of population. One is the asymptomatic patient and another is a symptomatic patient. So what you see on the graph which is there on the left hand side, that the red curve which is being shown here is for the symptomatic cases. So in symptomatic cases, if you see that the RNA load generally comes down much earlier than that of the asymptomatic patients. So what does that mean? That the asymptomatic patients are more prone to spread SARS-CoV-2 infection as compared to the symptomatic patient. And if you see on the right hand side of the panel, you have the other graph where you have the acute phase and the convalescent phase or the recovery phase. The level of IgG is almost similar in case of asymptomatic versus those with the symptomatic. Although it is said that during the convalescent phase, the level of IgG may be slightly higher in asymptomatic than the symptomatic patients. So now coming to the lab diagnosis of SARS-CoV-2 based on the background which we now know about the virus or how it affects the immune process in the body. So as we do conventionally for all lab diagnosis, first is the sample collection, second is the transport, third how we can directly demonstrate the virus, and then serology. So the direct demonstration of virus, when we say that it can be viral culture or the plaque reduction neutralization assay, where you culture the virus and then you neutralize it with the known set of antibodies and look for the reduction in the growth of the virus. So that viral culture and plaque reduction neutralization assay can be done in the research laboratories for characterization of viruses, but is not used for laboratory diagnosis routinely in the patients. So what we are left with is real-time reverse transcriptase PCR, acronymed as RT-PCR, and antigen detection tests. Serological test has epidemiological role. As on date, in diagnosis, it has very limited role. We will see in coming slides. So first question always is whom to test. So anybody who is symptomatic or has a history of the contact with the symptomatic confirmed case, or is a symptomatic healthcare worker, or having any kind of severe respiratory illness, or has a history of travel, those all cases can be subjected for laboratory diagnosis or testing. In initial phase, generally we will see that the real-time PCR will be positive. In later phase, we know that although the patient may be infected, but RT-PCR or real-time PCR or the reverse transcriptase PCR has a very limited role to play with. Only thing is what we can see is appearance of antibody. Here I just would like to emphasize appearance of antibody or the absence of appearance of antibody typically does not exclude prior exposure to the virus. So the sample which is being collected, it generally, because as you know, respiratory tract is the primary organ or the primary system which is affected. So we are going to take the oropharyngeal swab and nasopharyngeal swab, and if patient is again is producing sputum or is intubated or any pulmonary diagnostic procedure is being performed where we have the endotracheal aspirate or the bronchial lavage, those can be taken. So the essential samples for diagnosis, when we say, it is the throat swab and the nasal swab. So the oropharyngeal swab and the nasopharyngeal swab. More preferred samples or the other preferred samples are the bronchoalveolar lavage or the BAL, tracheal aspirate or sputum. And for antibody testing, you can have blood. Stool shedding and urine shedding of the virus may also be, if required. Stool and urine can be taken, but generally they are not the preferred sample for the diagnosis of the COVID-19 illness. So when to take sample? So it should be taken within 3 days of onset of symptoms, but no later than 7 days, because we now know symptom onset generally happen between 3 to 5 days. So when you are taking it after 3 days of symptom, that means if the patient symptoms have appeared on the day 5, it's already on after day 3 of onset of symptom, is already day 8. So we also know that generally the live virus is shed only till the day 9th of the illness. Beyond it, in general population or broadly, it is not being shed. So that is why after initial 7 days of onset of disease or the contact, the sensitivity of RT-PCR will go down. So how to collect a respiratory specimen? So what you need is a complete set of personal protective equipment, starting from the scrubs to the apron, N95 mask, goggles, face shield, cups. How to wear PPE? What should be the order of donning and doffing? That you should know, but it is beyond the scope of today's lecture. Beyond the personal protective equipment, what we need is a set of paired nylon flocked swabs, one for nasopharyngeal aspirate, another for the sterile container, other for the oropharyngeal specimen, and then you need a viral transport medium. It is required if you are taking nasopharyngeal and oropharyngeal swabs, and if you are taking the urine or stool sample or sputum or bronchoalveolar lavage, then you require a sterile container in which you are going to collect a specimen and send it to the laboratory in cold chain. So combined nasal and oral swab to be collected in viral transport medium. All uninoculated VTMs should be kept at room temperature, and if there is any turbidity, that means these tubes are contaminated or viral transport medium is contaminated, so they should be discarded. So when you are putting the sample into the VTM tube, you must see that they are not turbid initially. All respiratory specimen collected in viral transport medium should be stored in dedicated refrigerator before packaging and transport if there is any delay in packaging and transport. So they should not be mixed with any other kind of specimens. So all specimen, if you see, be it nasopharyngeal sample or bronchoalveolar lavage and so on, all should be stored at 4 degrees centigrade or transported at 4 degrees centigrade. If they are being kept beyond 5 days, then they have to be at minus 70 degrees centigrade. So for all technical purposes, cold chain from collection to transport must be maintained when you are sending sample for the COVID-19 diagnosis. So nasopharyngeal swab, how we should take it? So there is a technique where you have a flocked nylon swab which easily bend on and take the shape of your respiratory tract. So we ask the patient to tilt head so that the angle is around 70 degree, and slowly you will start rotating the swab and enter in through the nostril and gently move forward till the time you hit the posterior pharyngeal wall or any obstruction which you feel around. So you will take several seconds to absorb the secretions and rotating it and move out of the nostril. The swab is moved out and then you can break the swab and put it into the viral transport medium. Similarly, oropharyngeal swab has to be collected like any other throat swab we collect. Only thing is you will not ask patient to say or use any tongue depressor, because more and more intervention you do or ask that person to speak or to raise voice to elevate uvula and all, there is a risk of aerosol generation. So you will ask the patient to open the mouth as wide as possible, insert the swab into the throat, and then taking the sweeping motion, just touch the pharyngeal walls or tonsillar pillar and move out. Do not try to touch the swab to the posterior pharyngeal wall, because again it will lead to gag reflex and dissemination of the aerosols. So again, this swab which you have taken from the oropharyngeal mucosa, again has to be broken for the extra stick, and it will go into the same viral transport medium tube in which nasopharyngeal swab was taken. So both samples are to be kept in a single viral transport medium, while use of calcium alginate swabs or the swabs with wooden shafts are not recommended, because they may contain substances that inactivate virus or inhibit the PCR testing. So it has to be blocked nylon samples or the swabs which are being used for the sample collection. So
step 1. Wash hands thoroughly with
this is just a step, various steps to take the NP swab.
Step 2. It is important to always wear appropriate personal protective equipment, PPE, when collecting clinical specimens. In this case, this would include the use of goggles for eye protection, a surgical mask, and gloves. Put on the mask, goggles, and gloves. Step 3. Remove the viral transport media, VTM vial, from the packaging and label it with the date, patient identifiers, and any other required information. Step 4. Ask the patient to blow his nose and dispose of the tissue in the biosafety bag. Step 5. Position the patient in a comfortable position, if possible, with his head against a wall to ensure that he does not move during the sample collection process. Step 6. Remove the OP swab from the packaging and insert it into the posterior pharynx and tonsillar areas. Rub swab over both tonsillar pillars and posterior oropharynx, and avoid touching the tongue, teeth, and gums. Step 7. Place the swab immediately into a sterile vial containing 2 milliliters of VTM without antibiotics. Step 8. Aseptically cut or break applicator sticks off near the tip to permit tightening of the cap. Step 9. Remove the NP swab from the packaging and insert the swab through the nares parallel to the palate, not upwards, until resistance is encountered or the distance is equivalent to that from the ear to the nostril of the patient, indicating contact with the nasopharynx. Gently rub and roll the swab. Leave the swab in place for several seconds to absorb secretions before removing. Note that tearing is a normal response to the insertion of the NP swab. Step 10. Place the swab immediately into a sterile vial containing 2 milliliters of VTM without antibiotics. Samples can be placed in the same vial if desired. Step 11. Aseptically cut or break applicator sticks off near the tip to permit tightening of the cap. Pillars and posterior oropharynx, and avoid touching the tongue, teeth, and gums. Nasopharyngeal swab.
So now you have seen that how to collect the nasopharyngeal swab and the oropharyngeal swab. So then the blood collection of the positive cases, again, it has to be depending on what you want to use for. If you are using it for PCR, it has to be in EDTA vial. And if you are using it for the antibody testing, it has to be in a serum tube or the plain vial. So the important point is that the all BSL-2 containment, biosafety level 2 containment level is required for handling of the samples, and consider all samples as potentially hazardous because you do not know which patient is infected and which one is not. Handle all specimens with gloves in a secure manner.